So in a previous video, I talked about how we tell when someone is nearing end of life. And now what I'm going to be doing is a series of videos that discuss and that cover what it actually looks like when somebody is dying. And I'm going to go through these kind of a little bit piecemeal through each body section or system, depending on what we're talking about, what we're discussing. And especially for someone who maybe has never seen a death, I think it's important to understand what it could possibly look like, because in an effort to ensure that we all die better at end of life, having some understanding of what death can look like, the good stuff as well as the challenges, can help us in terms of how we make our medical decisions, how we want things to look like at end of life, et cetera, et cetera. So we're going to get into that. This is going to be one of many videos. And today I am going to start with something called terminal agitation. Hi, my name is Abigail. I'm here to ensure that we die better at end of life by normalizing these conversations and education about death and dying. Let's get into it. So at end of life, it's not uncommon to actually have symptoms that pop up. Not everyone is going to die with a completely, flawless death without any kind of symptoms. That's just not realistic. Mostly because, people who are dying usually have some kind of condition or conditions, diagnoses with which they have been living for a certain period of time, and that can impact end of life symptoms. And those physical, attributes to a person, as well as the emotional and mental components to that person, can also impact things, especially if you have things like a history of trauma or some kind of other psychological distress or spiritual distress with which that person is dealing. So in this video today, I am talking about terminal agitation. Terminal agitation is kind of what it sounds like if you can kind of pick up the words. Terminal meaning end stage, happening at the end stage in someone's life, so in the dying process. And this can happen anywhere from, the last minutes to the last hours to the last days even. Sometimes it can last a little bit longer than that, depending again on what's happening. And agitation is simply what it means. It's agitation. So some people say, kind of interchange that with anxiety, but it's truly, a state where somebody is experiencing some agitation due to a number of factors. And it's usually something that not only is it terminal, but sometimes it can be a little bit different than what people usually assume agitation may be. So we know that this is an agitation that occurs at end of life. And the reasons for it are, again, it can be physical, it can be emotional, mental, spiritual. Physical reasons or, for terminal agitation end of life, usually, from what I've seen, usually have been due to something like pain, pain that's not completely treated, or something like, shortness of breath. If someone is dealing with any kind of respiratory, lung, or cardiac heart issues, or anything that is impeding or impacting the ability to really breathe comfortably, you can have agitation there. And the reason why is because when you can't breathe, you naturally get anxious, right? If you're holding your breath for a long time and unexpectedly for some reason, you are already, you're getting anxious. If you're having, if you have asthma or asthma-related type of issues, anxiety is a natural part of it. It's natural for us to become very anxious and uncomfortable when we can't breathe normally or comfortably. People with COPD, chronic obstructive pulmonary diseases, and other type of heart diseases, or if they're dealing with a pneumonia or something like that, or other respiratory infection or bronchitis, something like that. Or if something is mechanically impacting their lungs, so it's any kind of, intra-abdominal, any type of cavity, type of tumor that is pressing up on the lungs, shifting, these organs around, that's keeping somebody from breathing comfortably again. So, or any kind of even lung cancer, metastases, any things like that, a pleural effusion, where there is some space in between, these certain cavities in the chest and the lungs. So, or a cardiac effusion, again, that's, in the heart space and between the linings there. So there are so many cases, if you're having any kind of liver issues, where you're developing an ascites, where fluid is developing in the lungs, things like that. So anything that is impacting just the normal physical need to breathe and breathe comfortably, that can certainly impact. And, when I talk about pain and that there's so many different types of pain that we, deal with, not just physical, but it could just be not only pain, but just discomfort from, retaining urine, for example, urinary retention, or bowel retention, as sometimes I call it too, when you're really badly constipated, or any type of pain from anything else. So, typically those are the things that I've seen as causes for agitation. Someone may have not been able to rest well. So, if you're not rested well and you're having any type of symptoms, again, that could really add to agitation. The non-physical, and there's so many things that I'm not even dealing with here. I'm talking about like things like skin wounds and all these other things that can be a part of it. So any type of physical thing, you always really want to rule that out to make sure that there, are no physical issues that could be contributing and or causing this agitation. And make sure that we treat those things. We don't just treat the agitation, we treat the pain, we treat the respiratory distress, the inability to breathe properly, things like that. We treat the constipation, the urinary retention, things like that. Non-physical type of things, and again, the physical list can be much, much longer, but I'm speaking in generalities just for the sake of not driving everybody crazy on this video. I'm not making it hours and hours long. Non-physical type of pain can be something like a mental, emotional, and or spiritual distress. We cannot count these out. This actually is very real to the person who is experiencing terminal agitation. And so if there's any type of spiritual distress, mental and or emotional distress, that can manifest as terminal agitation. And this is a very, challenging type of case that you have to deal with. So we're going to talk about how we actually manage these things down the road. But first, let's talk about how it actually looks like. So terminal agitation is an interesting one in that many times the person is not how it looks like, how it can actually look and actually look like at the time of death and getting towards death, The person may not be completely conscious and may not be fully aware of themselves or what's going on necessarily. So the agitation, while someone can still present with agitation, they're not going to be necessarily making eye contact with you and being able to coherently, verbally tell you what's going on, that they're actually agitated. You're actually watching this and observing this agitation. So likely symptoms are things like confusion, feeling or seemingly unsettled. So they could be very, very confused. They could be, even though they're not making any kind of eye contact with you, they're not able to, interact with you, cognitively. They could be having their eyes, closed or maybe open a little bit. Their eyes could be fluttering. Their facial expressions could be grimacing. They could, be shaking, and they could be pulling at things. They could be fidgeting with their sheet, their clothes, trying to take them off. Maybe they're, maybe because they're hot or for some other reason. They could be just moving around in the bed, and they could even be having higher risk for falls and even actually rolling out of bed. That is considered, a fall once they make contact with the floor, or trying to keep getting up, and trying to even walk, but they can't, and they usually fall. So it's a very unsettling type of situation where the person clearly is unsettled, clearly is uncomfortable, and is clearly agitated for some reason. And usually, vital signs, heart rate is usually up, the breathing rate is usually up, blood pressure could be up or down. Again, it could be another contributing factor. And the person could, be mumbling to themselves, could at times be screaming, or shouting certain things, or maybe they're trying to talk to some people. That's my little cat back there, saying hello. So, these are just kind of the general type of things. And again, they could be doing things like shaking, they could be trembling, any of those types of things, any of these types of, type of agitation, type of signs and, symptoms that you may see. But again, what's interesting here is that the person really can't, particularly at end of life, they're not necessarily coherently communicating with you, and they can't really cognitively connect to the person that is also there with them, present with them, trying to, maybe trying to assess them or make sense of things. So it's a different thing than when someone's maybe having like, a panic attack and that panic attack is a very, intense experience, but people who might have a panic attack can maybe sometimes, still, follow instructions that somebody's telling them, be able to at least grasp the hand of somebody and try to at least, coordinate their, cognition somewhat with somebody who's there and trying to help them. In terminal agitation, you don't really see that. You don't see any type of cognitive connection with another person. You really see someone who is in that active dying phase, and they are, not really seeming like they're comprehending. They're not really able to cognitively make sense, excuse the sirens. So, but they're agitated at the same time. So what do we actually do in cases like this where terminal agitation is occurring? So like I said, you obviously want to treat the trigger. If it's a physical thing, obviously you treat that physical thing. So if it's pain, or if it's any kind of discomfort related to pain, or, like we said, constipation, urinary retention, if there's fluid buildup in the belly because of liver ascites, things like that. All these things, you definitely want to treat as much as possible. So does it mean that at end of life, you're going to ship that person to the hospital and get them drained with their abdomen if they're, literally hours away from dying? Not necessarily, not really. You're going to treat medically usually. Treat medically and treat with other type of non-pharmacological interventions. Medically, obviously, you use a blend of medications. Don't just treat anxiety, because if you just treat anxiety and there's an underlying trigger for that anxiety, then you're not really treating the anxiety effectively. You might put a Band-Aid on, and maybe someone, you give a little anxiolytic or a little Ativan or whatever, Xanax, whatever it is, and they kind of seem a little calmed down. They're never going to fully be calm and comfortable if you're not treating the trigger and the cause for the anxiety. So always really, especially for clinicians, you do their full head-to-toe assessment. We're talking physically right now, and you really look at your diagnoses related, comorbidities, things like that, and obviously look at their history, things like that. Treat the cause. So if we think, if they have a cardiac or respiratory issue, make sure that we're treating that, make sure that we're possibly a little bit of hit of morphine is going to work, or, to help with things, the respiratory issues. Or if they have things like metastases, bone metastases, maybe we work on getting a little Solumedrol, or, do some NSAIDs in addition to the narcotics to really help with the pain of metastases. And, and then we can always pair those with with the anxiolytics, with anxiety medications to really keep that person as comfortable as possible. And when we come to things like mental, emotional, and or spiritual distress, we absolutely must treat those. And this is where we really need to not only bring the medical side, here to treat the patient, but we need to bring the other counselors. So this is why you cannot die without hospice. You need to bring the appropriate counselors and the spiritual care counselor, social worker. And even though that person cannot talk to you, you can still therapeutically talk to this person. Use your knowledge, use your, the information from your initial assessments, your ongoing assessments, to see what could possibly be causing this person distress. Is it something, in their past that we need to talk them through? And again, they're not going to be there. The person who is experiencing this terminal agitation is not going to be able to interact, but the counselor, the person who is treating the person, can walk through and say, you shared with me one time that you felt really guilty about the relationship you have with your daughter. I'm going to talk you through this because I I'm giving you permission. For what it's worth, I'm giving you permission to forgive yourself. It's okay to forgive yourself. And it could be, getting the daughter on the phone. Maybe the daughter, who knows where she is, but it's an opportunity to say then, even if you can't get the daughter on the phone, how do we, to say that she forgives or whatever else that she needs to say, that's true to her. But maybe, we use certain other therapeutic lexicon to really help carry that person through. I'm not going to pretend to be, an expert on the psychotherapeutic part. I kept things very simple, especially when I was a nurse and doing these types of therapeutic. It's not a dialogue because I'm not dialoguing with them, but, when I would speak to my patients who were dying and, giving them the opportunity to consider forgiving themselves and letting them know that I am here and I am letting them know that it is okay for them to forgive themselves. And there is, room for that always, that I, believed. And again, I always included whatever type of, language, terminology that spoke to them, based on the team's assessments, because you need to do that. You need to speak in their language and their own lexicon. So really important to delve into those. There is another thing that when terminal agitation can't be treated effectively, there is another type of treatment that you can bring in. And this does require a different video because it's much more, it does require much deeper discussion, but I'm going to mention it here because it's very applicable. There is something that you can do called palliative sedation. And this is where you deliberately, it involves additional paperwork, consent forms. It involves, things like continuous care or moving the person to a facility. Really, really important on cases. You don't have to do a palliative sedation in a facility. You can do palliative sedation at home, and we've done that in the past at my old, job. So it's a very intense form of treating somebody where you are deliberately getting them to a state where they are sedated in order to help them be more comfortable. And again, what I want to emphasize here is that you absolutely must establish a policy and a protocol. People who are going out there, any staff who are going out there must be fully educated. The family must be fully informed and educated of what's going on. They will be signing additional paperwork and consent, like I said. And the level of care usually should be changed. You usually should have that patient on for clinicians on crisis care or GIP, depending on where they are in the situation. So it does involve much more intense monitoring. It's like bringing that person to an ICU level of care because you're giving them, medications that aren't usually given because palliative sedation does require sometimes a different type of medication depending on how effective certain other non-effective certain other medications were. And like I said, I'll do another video on that because it does require more explanation. So, but terminal agitation is something that definitely happens at end of life. And if it happens, it doesn't mean that it's going to be a horrible, horrible thing. If you have the right care in place, end of life care in place, like i.e. hospice, again, nobody should die without hospice, then you're going to be, you should be well treated and well managed. So this is again why we talk about these things. This is again why we don't just wait till last minute. It's important to understand what's going on with you physically or your loved one physically. It's important to understand how soon you can bring hospice in, how important it is to have the right types of plans and medications and interventions lined up. I really focused on medication type of things, but other type of things, for the emotional, spiritual type of distress, it's very critical that you incorporate those. Other non-pharmacological types of things do include things like, putting a fan on if someone is having shortness of breath, doing things like aromatherapy or other type of integrative type of therapies, pet therapy, things like that. Working with the environment, the lighting, the right music, things like that. So you never want to leave those out ever, in these cases. So I know there's probably a little bit more to delve into here, but I wanted just to kind of start this off and at least, address this because it is something that can happen, and can be common at end of life for certain reasons. But there are certainly ways that we can actually make sure and ensure somebody is comfortable when they die. Let's continue to normalize this education and conversation about end of life so we all die better when the time comes. I'm Abigail. Thanks so much for joining today.